Thank you, June. And June is one of the junior faculties I'm extremely proud of having been able to mentor. And we continue working together because we're having fun doing so. And some of the results you'll see are actually from what we're doing together. So she already introduced me as somebody who is not very focused. Just a warning to you, whenever I talk to juniors, I say don't try what I did because it might ruin your career. Focus, at least for a while. Since I'm an MD, none of these outcomes scare me because, you know, that's what medical school teaches you, to kind of be a generalist in many ways. So that wasn't ever a problem. What is actually much more difficult for me is to wrap my mind around all the exposure assessment tools and issues, and that's what I've been struggling with for the last 20 years. And it's now 20 years that I've been doing this, since 1995. So next year it's 20. So when I started as a junior faculty at UCLA, I really had no research funding. I had a computer and I had time. And the first studies I'm going to show you were just, you know, that kind of investment. I had also colleagues I could ask for help. So the first 5 years I spent just modeling away with, as long as my computer allowed me. And in '95, believe me, it wasn't easy. The exposure models I'm going to show you, which are very simplistic for 120,000 births in the South Coast, took 2 years. And we can now do that in 2 hours with a little bit of programming, right? So some of this really was long-term then and would be very easy now, but now you have IRBs that are much stricter, and it'll take you 2 years to get the IRB approval and the data. So I'm giving you the runaround today with these air pollution studies. We are starting where I started with adverse birth outcomes, and then we also more recently actually started to look at neurodevelopment, childhood cancers, and neurodegeneration, and that's how I will end. But most of half of what I'm going to talk about is adverse birth outcomes, which is where I started. So we have in epidemiology something we call the life course perspective. And the life course perspective says that there is that part of life here in fetal development that's really relevant for everything else that happens later. So the way we are setting up organ systems, including the brain of a fetus, might determine not only how the child's neurodevelopment goes, but also whether you are healthy at an older age, and also sets up how you react to all the exposures over the lifetime that then may decide how your end of life looks like, right? So that's that kind of perspective. And I'm listing the outcomes that I've been studying, and the last one is Parkinson's at, older age and retirement. But honestly, some of Parkinson's, I'm now absolutely convinced, starts here in fetal development. Because the neurons that degenerate to give us Parkinson's, the dopamine neurons, we are born with, and so far everybody believes they don't divide. So you're born with a number of cells, and the only thing they do over a lifetime is die. And there's a normal rate of death in these cells, and we have incredible reserves in a sense that you do not get Parkinson's until at least 60% of those cells are dead. So you have a lot of reserve. But how many cells you're born with and how your brain is formed determines when that 60% capacity is reached. And people with less neurons might actually reach that point much earlier. That's why I'm thinking that this whole perspective is quite relevant for neurodegeneration at an older age. So the challenges of what I've been doing can be outlined in this way. It's, of course, exposure assessment, but not only the assessment of one exposure at a time, but also the multiple correlatedness of exposures that's hard to grapple with in these kind of studies. And then something that I spend my time on trying to explain to people, which is what is the difference between a record linkage and a birth cohort study versus a case control study, and what are the advantages? So I kind of call myself the queen of record linkage. The reason is that I use the birth certificate, the cancer registry, the Department of Developmental Records, anything that the state of California graciously collects in a surveillance kind of manner, and that now can be linked because we are allowed to use to link by name or by social security number and have the addresses and geocode them and assess exposures. The big advantage of such a record linkage is nobody can say, no, I don't want to participate, right? And whenever we have a cohort or a case control design, that's our big worry. The cohorts are the willing volunteers. They never look like the rest of the population. They're the ones who want to do this, and they better are the ones who want to do this because you want to follow them for a very long period. So actually my former chair, Dr. Olsen, who founded the 100,000 baby birth cohort in Denmark being followed, his motto was, if in doubt, stay out. He does not want you in his cohort if you're in doubt that you want to be seen, okay? Case control studies are even worse because you start at a time when the disease has already occurred, and then the people who have the disease might be happy enough to participate if you can find them. Try to find Parkinson's patients in the state of California. Not easy. There's no registry, right? That was a big deal. But then go and find the controls that are supposed to be representative of the source population that gave rise to your cases, right? That's not easy either, and those controls are fickle. Some of them don't want to participate. You have to convince them that it's a good thing to participate in a study, even if it's only one interview. Why would they want to be interviewed and tell you all this stuff? So there's lots of potential for selection bias in these kind of studies. And there's lots of potential for these cohorts not to be representative. And that's why the record linkage in environmental health is kind of a godsend. As long as we can do it and we do it well and we have large numbers. And what I'm often struggling with explaining to lab scientists is that this is not the same as doing an ecologic study. Because they often comment on my studies, oh, and now Dr. Ritz will tell us something about her ecologic studies. It's not the case. They are not ecologic. Some of the exposures might be measured at an ecologic level, but then we link them to individual health data, right? So they are individual level studies. And the beauty of these record linkage is that some of the confounder variables we definitely have available to us because they're on these records, like the birth records have a lot of information on the mother's education, age, etc. But of course, they also lack some of the variables we really would like to have, like smoking. California did not collect smoking in pregnancy until recently, did not collect weight, really a problem. And then we are helped out when we're doing spatial and temporal analysis by this contrast where we can say, well, is it a temporal contrast I'm looking at or a spatial contrast? Because confounders have to be correlated with the exposure of interest, right? So if I'm interested in a temporal contrast, the confounders, those risk factors for disease, have to also be changing temporarily. If they don't, they are not confounders. And for spatial contrasts, it's the same. And luckily, oftentimes, the temporal and the spatial confounders are different. And when you see something with a temporal and a spatial model, then you can be much more sure that it's not confounded. And that's how you make your arguments in these kind of studies where you always miss something. And then selection bias, when you actually have access to these cohorts or case control studies, you have to consider how to think about selection bias and what it could be and how it could change your results. And I'll show you an example. So start with birth outcomes. This is really a Southern California story. At the time in 1995, when I was searching for data I could analyze without money, this paper came to my attention. And is an old UCLA paper from the Department of Anthropology. And these anthropologists, Susan Williams and Ann Spence, they actually used a map like this and then determined what the areas in LA, so this is LA, what the areas in LA were with the worst air pollution. And they had some measurements from stations in the 70s, but they really had a mixture, and it was very hard, but they came up with these areas. And then they took women who were non-smoking women at Harbor, UCLA, who had spent their pregnancies in these different districts, and looked at the birth weight of the children and determined that on average, the ones in the worst air districts, the babies of these non-smoking mothers were about 314 grams less in birth weight. That is huge. A child weighs between 3,000 and 3,500 grams. That's 10% of the birth weight. If you are an active smoker, you need to smoke 2 packs of cigarettes a day during pregnancy to get that kind of weight loss. That's how bad the air was in the 70s in LA. Okay? Not a good news. Interestingly, this was completely ignored by the environmental scientists. They probably never even read it until I found it somehow. And so nothing happened after this. There was one other paper by David Savitz on Denver and CO, because Denver is a high-lying area where CO is very high, and he found nothing for CO in Denver. That was in '89. But otherwise, it had been completely ignored throughout. So when I started my research, I was really helped by a few things. My research was in the South Coast Air Basin, and I quickly found out that half of all births in California actually happened in these 4 counties. So that's where we have a high population density and a lot of births. So I knew I had big numbers, and I knew I needed big numbers because I did not expect in 1995 this effect being as large as 10% of the birth weight, right? I knew there had been a lot of controls put in place, and the air was 100 times better than it was in the 70s. So I knew I was trying to estimate probably smaller effects, but the size was there. We still had higher air pollution levels than many other states, and we had a dense air pollution monitoring network that would help me out. And this is how my first map looked like. So here are all the air pollution monitoring stations for LA, and these are actually the ones that measured CO, because I came from a biologic background, and CO causes hemoxyglobin and causes low oxygen, and is thought to possibly have an effect on birth weight through that biologic route. Even though the ambient CO I could not really convince myself would have that kind of biologic effect. But people convinced me I should start with something that at least vaguely had a biologic effect. So I started with CO, and that was really lucky because CO turned out to be an incredibly good marker, but not for hemoxyglobin in biology. It was an incredibly good marker for traffic in the early 90s. So here are just these monitoring stations plotted all over, and the light yellow stuff was the size of a census tract, because the birth records at that time did not have anything except the census tract, the zip code, sorry. This is zip code. The zip code electronically available. So I used zip codes within 2 miles of a monitoring station in order to reduce exposure misclassification. And these are the zip codes where the moms lived. And you can see I excluded the zip codes where a large 60% of the area was outside of the 2 miles. I also tried to go with wind direction, but that didn't always work. So when I used these kind of monitoring station estimates, and I looked at different trimesters, because we know that early pregnancy has a different biology, that all the organs develop, while the end of pregnancy is mostly weight gain. So if I'm interested in low birth weight, I definitely need to look at the 3rd trimester, because that's when the fetus exponentially grows, right? So my first outcome measure was term low birth weight, which is definitely intrauterine growth retardation. And my hypothesis was that I needed to look at the 3rd trimester, but I also created estimates for the 1st and 2nd, kind of as a null hypothesis. I shouldn't see anything here, but I definitely should see something here. And you can see it worked out. I saw 6%, but wide confidence intervals, at lower levels of CO, but then at very high levels of CO in the third trimester, you see that 24% increase in risk when you're living within a 2-mile radius. But look at that confidence interval. I could not have gotten that published because people believe in these, alpha levels 0.05. So 24% possibly, but the null value, very nicely enclosed in my confidence intervals. So what do? You have to increase sample size, right? So when I go to a 5-mile radius, which people told me not to do because the exposure misclassification increases and there are lots of different people who live there, so confounding increases. Guess what? My effect estimate did not change at all, but my confidence interval now is nice, right? I can claim this is statistically significant. I have a 24% risk increase for low birth weight in the third trimester for women who live within 5 miles. But again, I told you just that now we have also a lot of different women included. So what kind of very simple sensitivity analyses are possible that help me out here to say, well, what kind of confounding am I not controlling for? And so I split my samples from all children, and a few had to be kicked out because of the way I analyzed this. And you see a 22% risk increase in that confidence interval I just showed you. And then we just looked at higher parity children. So these are mothers who already have a child at home. And the reason why I looked at these alone was because I said they don't spend too much time outside the area where they live because they have another kid to take care of. So their exposure assessment should be better, because one reason why I have exposure misclassification is I assume they're at their residence or in their neighborhoods, right? Because that's where I'm measuring. But they might not be. They might work somewhere else. So these women, I hoped, were more often in the neighborhood and maybe even outside with the other child. And look at this, exactly what you would expect happens. The risk increases to 33%. That's when you reduce exposure misclassification. And then I also looked at the subgroup of young women who are under 20 years of age. And look at this 54% risk increase with the highest CO levels. And this, again, the argument was they're even more likely to stay in their neighborhoods, maybe be even at school or at junior college, or they are the more vulnerable to the pollution in the area. So all of that could be the case. Some of those very simple, very easy sensitivity analyses you can do with a data set like this. At the same time, I was actually linking my data to the California Birth Defect Registry. And now I'm interested in a very different timing of CO. And it's the timing of the second month, because that is when the heart really develops. And you can see I saw a very strong dose response for that period that I had thought should be the one where the heart develops. And I don't see it in the first month, and I don't see it in the third month. I just saw it at the time when the heart developed. Again, with those simple CO measures at stations, and I had to go as far out as 10 miles, and that made me really worried. When we finally had addresses on the birth certificates, starting in 1994 in LA, we were able to look at this issue of distance from the monitoring station. So what happens if I only include women within 1 mile, within 2 miles, or within 2 to 4 miles? And here are the results, exactly what you would expect. So my zip code level analysis still gets me my 8, but this is just in LA. No, this is just in LA, not South Coast. The results before were all 4 counties. So 28% risk increase for term low birth weight. And now when you're looking at homes within 1 mile where the exposure misclassification is the lowest, you get 36%. So that's the highest. But as soon as you go above 1 mile, look at how your estimates drop, 10% and 8%. And that's exactly what you expect when your exposure assessment gets worse. And this was a very simple way of checking that. All right, so I already gave it away. CO was not the biologic agent of interest. CO was really a marker of traffic exhaust. And one way to show that was in the RIOPA study, where my colleague Michelle Willem got access to data where we asked the RIOPA people. RIOPA is a study of indoor, outdoor, and outdoor air pollution with distance to roadways and freeways. And we asked them to place a CO monitor for us, and they did. And you can see here that the closer you are to a freeway, the higher the correlations between in and outdoor, which was another measure of, okay, you're close in your residence, you are having high CO levels at the monitoring station, but does that get into the home? Is outdoor the same as indoor? And this study kind of showed that indoor and outdoor did correlate very nicely when you are close to the sources, which are the roadways. CO is a roadway marker. So when we saw that, we thought, well, maybe we can just use roadways to assess exposure instead of the monitoring stations, right? Because we have such an abundance of roadways in LA. So let's use those. And we started going after annual average daily trips. And we measured the distance from these, from the freeways. And we measured something called the distance-weighted traffic density, where the home is plugged here, and we are counting all of the traffic in the vicinity of the home, actually within 750 feet buffer. And that comes from that curve I just showed you. This is about 250 to 300 meters, where it dropped down to 0. So we use that buffer. And guess what? Yes, we saw effects on low burst weight, but I'm showing you effects on preterm bursts here as well, where for all bursts, it looks like, yeah, once the traffic increases to the third or fourth quintile, there's definitely an increase in preterm bursts, but it's not such a beautiful dose response. There's something there. And then we split our data in summer bursts and in winter bursts, and you can see that the dose response is much bigger in winter. And that is because there is that inversion layer. You see, this is not fog, this is actually smog in the 50s. But what you can see here is that the buildings are above it. So this keeps the inversion layer, keeps the air in place. And that's much more the case in the winter than in the summer. In the summer, you have a mixing height that is higher, and you have winds blowing that are stronger. In the winter is where you are at the breathing level within a local environment that's much more influenced by what's happening around you, and traffic is what's happening around you. And this was a really simple thing to do, split it in summer and winter bursts. It also tells you that preterm bursts is also, in this case, triggered by the end of what happens in the end of pregnancy. It was actually about 6 weeks prior to birth. And then June came around and had this beautiful data from hospitals in LA and Orange County, 4 hospitals. She had 81,000 birth records here. And she was able to now run a much more sophisticated model. We are now in the 2000s. We can actually do something with our computer capacity. And this is a dispersion model, a line source dispersion model to estimate traffic. And that model does not model CO, but it modeled NOx and PM2.5. And here I'm showing you the preeclampsia outcomes, but we also saw that for preterm births and very preterm births. And you can see there's a nice dose response here, unfortunately, with these roadway emissions now modeled by the CalLine model. And this was a very nice publication that came out in Environmental Health Perspectives. I, in the earlier 2000s, got funded by the NIEHS, and this was actually the only national funding I've ever had for any of that research I showed you. Everything else was done without resources. And this was a project that was funded to just look at confounding, because every time I would get up and show the slide I just showed you, somebody would say, but you didn't measure smoking in mothers. So I don't believe anything, because it's probably the smoking women who live close to the roadways and the freeways. And they were not convinced that maternal SES and education that we had on the birth certificates were a good enough surrogate for this kind of behavior, or race, or age of the mother, or whatever else you can come up with. So the goal was now to actually collect some indoor pollution sources, some in-transit exposures if we could, and some individual levels of time activity, smoking, alcohol, diet, occupation, and psychosocial stress. And so for 1 year in 2003, we interviewed 2,500 women 3 months after they gave birth, right when we got the first time we could get a hold of a birth certificate. And they were selected from a birth cohort of 56,000 women at random. We actually had selected 5,000, but we could only find 2,500. And that's what I told you, right? It's really hard to get people, find them. The ones we found all were happy to answer, but we couldn't even find them 3 months after birth because they had already moved. And we didn't have the money to go to their homes and knock on doors. We had to try to call them and send them mail. So we surveyed 2,500. And by the way, I'm going to show you that none of these factors were actually confounders, as I had predicted and argued until I was blue in my face, but I could finally show it. But what I also want to point out that the in-transit exposures were really not what we could measure. But what we asked the women was whether they worked outside their home. We also asked them where they worked, but that was much harder to really ascertain. But when we split our sample into the ones who did not work at home and the ones who stayed at home during pregnancy because they didn't have a job, the risk estimates doubled and tripled. So again, exposure misclassification because somebody is not at their home was extremely important. Indoor air pollution sources did not matter much, and neither did these confounders. So this is the table that shows you up here is the estimate for term low birth weight and CO, now adjusted for maternal smoking, for alcohol use. So this is maternal smoking, 1.3, nothing changed. Alcohol use, if anything, the estimate goes up to 1.4. Living in the house with a smoker, it goes down to 1.2, 20% risk. Married, 20% risk. Income, 30% risk increase, and then another income variable again. So we're hovering around 20 to 40% risk increase no matter what confounder we put in the model. And we can keep doing this, it doesn't change. And we can put them all in the model and it doesn't change. However, when we're putting them all simultaneously in, we are getting a risk estimate of 1.32 for CO here. And we kind of knew that that was wrong. It was an overestimate. We should have gotten something closer to 1.2 because in the birth cohort, this is what we saw. So my record linkage at this time in 2003, remember we are now moving, my earlier studies were in 1990 through 1995 through 1998. Now we're in 2003. Air has gotten even better, right? And we are still seeing in my birth cohort a 15% risk increase with these CO exposures. But in my case control study, when I find the women, it's double, it's 1.33. And we figured out that this was, with a two-phase estimator, where a very talented student of Dr. Greenland's helped program all this, and in a hierarchical model with a weighted likelihood, a penalized likelihood, a maximum likelihood, we could bring this back to a 1.2 with preserving these confidence intervals that we had in the birth cohort. And we figured out that that was all due to selection bias from the women who we had been able to get into this case control study. But luckily, since we knew the birth cohort, we could use what we knew about the selection from here to there and adjust for it. Okay, that's what this method and this paper does. And that was this. Oh yeah, and later we were actually able to also not just look at CO anymore, but look at PM 2.5, which is in the same birth cohort and in the same survey. And this is important because by the time all this came about, I had convinced myself it wasn't CO. It probably was something like fine or ultrafine particles from traffic. But PM 2.5 hadn't even been measured when I started my work. PM 2.5 is now routinely measured since 1999. That was long after I started this. And I needed a few years of data to accumulate, right? So in my birth cohort at this time, for the first time with my 2003 birth cohort, I could show that, yes, we see actually an effect for the highest quartile of PM2.5, in this case actually in the first trimester for preterm births. And for preterm births, it was always the beginning of pregnancy, much more than the end of pregnancy, as we later found. And that's probably because it influences the establishment of the placenta, and then the placenta and what the placenta does determines whether or not you're preterm. So the beginning of pregnancy seems to be more important for preterm births. We see an effect for PM2.5, and in our survey, it's again a larger effect estimate, but it's the fully adjusted one, and we know that this is probably slightly biased. And Yifeng Zhu, who's at UCLA, in the meantime was funded through the Particle Center at UCLA and moved her equipment measuring fine particles and CO and black carbon away from the 405 freeway in the Veterans Administration Cemetery. And she published this beautiful paper that showed that downwind from the 405, but not upwind, you have this incredible spike in measurements in particle number, which are ultrafine particles, in black carbon and in carbon monoxide. And it drops with distance down to 300 meter downwind to background levels. And this is exactly, so I, just by accident, picked the right indicator, carbon monoxide, for ultrafine particles. But I only picked it as the right indicator up to the time when she did this measurement in 2002, because very soon after that, CO became almost an impossible pollutant to monitor because of the reformulation of fuel that took out CO. So it's not a good tailpipe exhaust component anymore, and it's not even measured. It's below the measurement level of most of the AQMD monitors now. So we lost our ability to use carbon monoxide in that way, that it would give us fine particles. Why is that important? Because ultrafine particles are not measured in any of our monitoring stations. PM2.5 is, and PM2.5 is not a great marker for particle number at all. It's a secondary pollutant. It's much more homogeneously distributed across the LA or the South Coast Air Quality District, and it's not a great marker of traffic. What we need is black carbon or carbon monoxide before the reformulation, but we don't have it, or we need particle counters, which we also don't have. All right, so ultrafine particles, why are they important? Well, they are high in numbers, they are low in mass, and when you look, these are the ultrafines, they're in the nanometer, less than 100 nanometer, and they're so the size of viruses and molecules. And if you have recently listened to the Ebola debate, they are sometimes called, these viruses are called a particle. They are a nanoparticle, and they actually behave like nanoparticles in many ways. And why is that important? Because they enter cells. And they enter cells without needing transporters, they just go through. And one of my colleagues at UCLA, Andre Nell, actually showed that certain ultrafine particles not only enter cells, but they are preferentially taken up by mitochondria, which are the energy makers of the cell, and they harm the mitochondria, and they can kill cells by being in those mitochondria. And guess what? The placenta is full of mitochondria. That's what the placenta lives off, because it is high energy dependent. So that said, we knew we needed a better model for traffic. And this is what we came up with in collaboration with Mike Jarrett, who's now our new incoming chair in environmental health sciences at UCLA, after having taken a detour to Berkeley. We're very happy to have him finally with us. So I have him closer and can work even more closely with him. This is the land use regression model he and I built, hanging monitors at 200 locations all over the LA area, and this is the map we created. And pretty much this is just a regression model that predicts these monitored values using land use data, covariates that we have for all of the area. And these covariates are building height, greenness, parks, It's, of course, traffic density, traffic composition, whatever you have that you can build a algorithm with, and there's actually the list of the ones that had the best prediction. And our prediction model did really well, over 80% for NO, NO2, and NOx, which we are using as traffic markers. But what you can see here is it predicts pretty much that freeway grid and the road grid that I showed you before. But it actually does better than our traffic density measures alone. So again, working with John, actually, we now used all of these different monitoring devices to see what we can find for preterm births. And you can see that CO still worked in our data, a 13% increase in risk, NO 11%, NOx 13%, nothing for ozone, weak signal for PM2.5. I already told you that's not a good marker for traffic. And these are our LUR modeled values. So for NO2, we get a 7% increase. And yes, it does behave well because that confidence interval is fairly narrow. But it doesn't give me much above what CO would have given me. But it's better than this NO2 that has a wider confidence interval because there's more exposure misclassification. That's the monitoring station measured one. And then Jun also created with her line source dispersion model, CalLine, estimates, and they are kind of for NOx and PM2.5, 4% risk increase, and the confidence intervals are fairly narrow. But you can see here that the simple traffic density measure does not behave as well. It has the smallest risk increase of these kind of traffic measures, even though it's fairly precise. Okay, so I have convinced myself in LA there is a problem with air pollution, there's a problem with traffic pollution, and we can now do this somewhere else because nobody believes you if you only do this in one place, right? So Jun wanted to do this in Orange County, and she used the monitoring stations, and yes, she saw the same kind of things that I've been seeing. And she used our land use regression model to predict the residential exposures to traffic, and she sees nothing. Okay, absolutely nothing. And the reason for that, she found out, was that the R-square for LA County, for the residences that she had, was fairly high. I told you above 80%, she finds 77 here. But for Orange County, it did not model well at all. So it told us our regression model built and validated in LA does not work in Orange County, so don't use it. She later hung her own monitors, built her own regression model, and she was able to reproduce the results, and this is taking too long. She was able to reproduce the results for Orange County. So exposure assessment done well and validated is the key to all of this. But it's also key that we keep in mind that there are different contributors to all of these pollutants. So we have here the measured pollutants, and they all correlate fairly well, and of course ozone negatively with most of the others because it's an inverse relationship. But they are not very reflective of what I'm measuring with my LUR. They're very low correlations with the LUR model, a little bit better with the CalLine. But the LUR is really picking up something different from the monitoring stations. The monitoring stations pick up everything that happens, all the sources. But this is the traffic component, and you need another model for it to show it. Another thing we cannot model very well, of course, are air toxics. And California has air toxics monitoring stations, unfortunately only 4 in LA County. And you can see what they do really nicely is give you a temporal picture, right? So this is benzene as an example, but you have a lot of different air toxics. And it seems to be very seasonal with winter spikes and summer valleys. So there is a great temporal component to this data. There's also a longitudinal temporal component here. This is 95 through 2007. You can see that overall it really got better in terms of benzene. monitored at these 4 stations, right? So some pollution control that the AQMD put in place did work, but no matter what they did, there was always that seasonality that kind of stays with you. So we used these 4 stations, and what they monitored drew a 5-mile buffer around them. And we also used 7 stations that were only used between 2004 and 2006 in what's called the MATES monitoring for LA. And you can see that's, again, this goods movements corridor where they actually did this. And in this MATES PM2.5 modeling, the specific interest we had was that they are giving you some kind of models for metals and PAHs and then some traffic markers as well. And you can see here when we're going down to the level of what are the agents in the exhaust, or the agents that we are monitoring, let's say CO or NO2 for, but we know they're just markers for some mixture, pollutant. We see benzene is definitely one. 4% risk increase for term low burst weight, and this is for that period 95 through 2006 when the air is already much better at the end. And at the 7 stations where we only have 2004 through 2006, we find a little bit, we start seeing a signal for benzapyrene. And we are now, that was low burst weight. When we're looking at preterm bursts, we are actually, and we're using those 7 stations again, we're seeing that we have something between a 12 to 21% risk increase for preterm bursts, depending on whether we are looking at organic compound, PM2.5, elemental, or maybe diesel or biomass burning. So that's what these models give us. They give us a much more specific exposure, but then you can see that all of them contribute no matter what we did. This is not old news. For me, it was all old news, right? Because I've been doing this for 20 years. But when you look at the newspaper in 2013, this is what China looks like right now, right? And those levels are likely what we saw in the 1970s in LA or in the 60s in LA, if not worse. Okay? So, and there are an estimate here that Nature published that about 3 million infants are born low weight and maybe preterm, or have birth defects because of air pollution currently in Beijing alone. And I had shown that all of these outcomes are relevant with Jun, that preeclampsia is also, and that's a very, very important complication of pregnancy that leads to preterm birth or a severe health effect in the mother. It threatens her life. And the cardiac heart defects that I showed for the 2nd month of pregnancy and road traffic is always important. We have a few more minutes, right?
Yeah.
Yeah? Okay, I wanted to show you childhood cancer briefly because after 20 years, birth outcomes kind of seem, okay, I've done that. But what we have never done was look at cancers because we didn't have the numbers. And finally, because California collected cancers at a state level since 1987, we have enough numbers to count all of the leukemia cases. These are the ALL, lymphoblastic leukemias, and look at entire pregnancy, in this case, exposures, but we can also look at pregnancy periods, end of pregnancy, early pregnancy, and traffic-related air pollution. And with our LUR model for LA alone that I showed you, we see a 9% risk increase for ALL. With the CalLine model that Jun, and she is a co-author on this, that Jun used, we are seeing a 4% risk increase for lymphocytic leukemia. And we are also seeing increases for retinoblastoma. These are eye tumors, and the children, if they have them on both eyes, they're blind. And that's this one. And for germ cell tumors. So we are, and all of these confidence intervals exclude the one, so we can show that ambient air pollution, in this case, actually did contribute to childhood cancers and from traffic sources. Okay. This is, another one where we're actually not using our LUR model or the CalLine, but the PM2.5 monitoring. and we're using a 5-mile buffer. And you can see we are also seeing that 10% increase in risk, but those confidence intervals are including the 1. And this is what you have been seeing so far in the literature. Well, there may be something, but you know, the confidence intervals never excluded the 1. That's the same estimate I showed you here for our LUR model for traffic. What's different? Our exposure assessment, it's better. I told you, and I hopefully convinced you, that PM2.5 is not a great measure for traffic. It's everything included that's a particle. And some particles are salt, some particles are dust. All of those count in the mass, okay? And therefore, our exposure assessment is much cruder, and none of these confidence intervals excluded the 1. But the direction and the size was comparable for the cancers. So we went and now used also the air toxics monitoring, not just the 4 in LA that I had shown you results for before, but the ones across the state. And when we did that, and again, I think in this case, I'm just showing you the 2 miles around each of these monitors because we have enough cases. And you can see that the 3rd trimester and the all pregnancy averages for total PAHs show 16% risk increase, 17% for retinoblastoma in this case. But we also saw similar kind of things for Wilms tumors and for ALL. So that's the cancers. We can, for the first time ever, show that there is an effect of ambient air pollution on childhood cancers. And these are, by the way, cancers that are less than, the children are less than 5 years of age. And it's highly likely that the exposure during pregnancy is relevant. We also modeled first year of life, but mostly pregnancy. So for neurodevelopment, I don't think I have enough time to show you this. This was just head size that we modeled, and we could show that yes, head size was lower with all of our measures. But that gave rise to this study on autism, where we looked at all the births between 1995 and 2006, and the autism diagnoses between 1998 and 2009, and we modeled pregnancy exposures. And when we did this, we had 8,600 cases linked to birth certificates of autistic children. That's a lot. We selected 10 controls from birth certificates at random without such a diagnosis, and we estimated effects for multipollutant models, in this case ozone, and our traffic marker NO2, the LUR model, and PM2.5. And you can see here that we estimated, again, 8 to 9 to 10% increases in risk with these traffic markers, and that was adjusted for everything on the birth certificate. But what was important is everybody knows that there are a lot more higher education mothers with children with autism, and that's exactly what our data showed. We had about 4,000 of them that had more than high school education, and then 2,000 and 2,000 for mothers with less than and high school education. When we are looking only among the women who have less than a high school education, that's when our estimates are the highest, 22% risk increase for our traffic model. And very little, a little bit for the more than high school. What does that mean? These mothers might be much more susceptible, or they are really in the areas where there's more pollution. We don't know. But it is, we have to be careful to look at these kind of effect modifiers for our results, and I think that's a good example for it. And this is the group that worked with me in Denmark, over 10 years collecting these data and modeling them. And I could not have done this without Michelle Willem-Turner, Joe Kay, Julia, Tracy, Jia Heng, Junwoo, Mike Jarrett, Miles Coburn at USC, who does my geocoding, and the generous contributions of CARP to build the LUR model, and some contributions from NIEHS and from UCLA centers. Thank you.